Okie dokie. So hi everybody, welcome to the CCSP, I almost said October call, but I guess we're November now. So, so happy belated Halloween and welcome for our check-in for our November call. We're really excited that we have some of my longtime colleagues and friends from South Carolina sharing some of the perspective about work related to response to COVID-19 and their prevention and control strategies. So we thought Elsa and I had chatted that we share a lot of information about what's going on with the program and the work that we're all doing and checking in. But we thought it would be nice to actually have some fresh perspective from some of our screening allies out throughout the country. So we're really excited to have Tracy Lewis and Renee who will be joining us today. We'll be sharing some perspective about the work and thinking about the strategies that we can continue thinking about for implementation in Colorado. So before ladies in our South Carolina team join and share a little further about the background, a little bit about their program, and then the strategies about moving ahead to really improve cancer prevention and control. Elsa, you want to go ahead and kick us off today, just sharing a little bit of general program updates or any general announcements before we dive in?
Sure. So thanks again, everyone, for joining today. It looks like we have a great group of about 25 people on today, seeing some of our faces from all across the state. And so I also just wanted to mention we are now officially into the second quarter. So if you have not yet submitted your evaluation or billing for September, please make sure to get those in as soon as possible. We really need to finish up our invoicing for the first quarter and all of that. We don't have any updates about an extension year yet for CCSP. We will be meeting with our CCPD program team tomorrow. So as soon as we have any more information about that, we will share that, since I know a lot of people have been interested to hear about that. I'm going to turn it over to Andy just to share a little bit of an announcement. You all may have heard that the USPSTF has put out their draft guidelines, which would move the screening age from 50 to 45 for average risk. So that's really exciting, and we wanted to make sure you all were aware of it. So I'll have Andy share briefly a little bit more information about that and implications. And then there was another opportunity for focus groups and interviews that we'll be sending out in the follow-up notes that I wanted to give Andy a chance to speak to briefly as well.
Okay, great. So as Elsa framed, the recommendation and the draft recommendation has been shared. It is open for public comment right now, and at the end, excuse me, of November, we will have the final comments to USPSTF, and they will take it under advisement, and it's very likely that that guideline change will be moving from 50 to 45, which means that for Medicaid, Medicare, as well as public and private insurance, we will see, because Colorado guideline follows USPSTF, that people who are 45 years old will now begin the average screening. That will be the average risk screening start date instead of the 50 to 45. We will be sharing some of the perspective. I'll be sharing when that comes into full consideration and implementation. We'll have a couple of our medical advisory team members, as well as myself, sharing what that means for the program, and then really how we're going to continue to implement. The program will, of course, continue to honor the USPSTF and ACS guidelines, which are now succinctly aligned if this does go to complete fruition, which we have every belief that it will. So I think Laura Martinez said it well in the chat, yes, with a couple exclamation marks. We're really excited about this work. We will continue to pay for those navigated based on guidelines of average risk as well as high risk population, and so more to come. This was a huge win. As you know, that we've all been very engaged in this work in Colorado. Dennis Annan was very engaged with our team as well as Fight CRC and really looking at this movement early on. So just great to see all of that come to fruition. The other thing I wanted to mention is there is an NCI Small Business Innovation Research proposal with several collaborators in Colorado looking at technology and application-based care moving ahead, specifically for those who are diagnosed with colorectal, breast, and lung cancer, and thinking about care coordination and even probably opportunities for messaging around screening. There will be some focused, targeted focus groups and interviews that will be happening through November and December. We would ask that if you're interested in helping, there's a $25 Amazon gift card for participation. We ask again that if you do participate, that you've received approval from your agency that you work for, and that you can accept the dollars or make a contribution to the facility that you work with. So we really like to have some great representation from all of you as well. And then the other small announcement, and I think Elsa will be sending out communications, the National Navigation Roundtable, where we sit in leadership positions, will be hosting their second in a multi-series annual meeting approach coming up. It will be hosted in early December, and they're going to be talking a little bit about strategic plan and strategy moving ahead. So if you're interested in, again, that workforce development and all things navigation, which 25 of you are on the phone, that's a really great meeting to really advance. So I think, Elsa, that covers it, and I will introduce Tracy and Renee quickly again for those of you who are just joining on. Elsa, is there any other update that I failed to mention?
We are good.
Okay, so again, a huge shout out to our colleagues over the years working with Frank Berger, Tracy, Renee, who are going to be joining, as well as a number of their colleagues. We really collaborated around what are our prevention strategies from a state level basis, as well as working with the NCCRT and other approaches. So we really welcome all of you from the South Carolina team to really share some perspective today. And I think, again, just to help change it up and really think about considerations for our work in Colorado, we can always strive to improve. So we're really grateful. So Renee and Tracy, I will hand it over to you to walk us through today's presentation.
All right, great. Thank you so much for that wonderful introduction, Andy and Elsa. And I'm going to share my screen so we can get started. As Andy said, I'm Tracy Lewis. I'm the Community Outreach Director with the Colorectal Cancer Prevention Network, and Renee Caldwell, who is our Navigator and Service Director for the Colorectal Cancer Prevention Network. We will be co-presenting today on some of our approaches to increase colorectal cancer screening in South Carolina. For some reason, it is not going forward. Huh.
I think you can use the arrow at the bottom of the screen at the left if it's not automatically going.
There, thank you very much. All right. Just wanted to kind of give you.
Before you move on, was that a Gamecock? Is that the South Carolina? Is that what that is on the front here?
Yes, it is. We truly love our Gamecock. We are at the University of South Carolina, and that is our cocktail. And so you will see it throughout the presentation. It is on our tagline. We just think it, represents our home and who supports us in this endeavor. So
it's all about the back end today. So this is perfect. I just wanted, for framing, I just wanted to make sure that I had that correct. All right. Sorry to interrupt.
No, you're fine. Thanks for asking. I think sometimes we forget people are not so familiar with our cocktail. So, and our mascot is Cocky. So it goes along very well. Just to give you a snapshot of our team, this is our entire team. We have our fearless leader, Dr. Berger, that Andy referenced at the beginning. He actually started the Center for Colorectal Cancer Research, and from there, the Colorectal Cancer Prevention Network was developed through his initiatives. Annie Thibault is our executive director, and Renee, those two basically have made our program what it is today. They were the ones that started the initial screening program and have built it to where we are today. We have 6 navigators that are regionally based, and then we have 4 junior navigators which run our data side of our program. Our mission is to reduce colorectal cancer mortality through education, awareness, and provisions of screening services. Just to give you a little bit of background and history of where we were prior to COVID and what has happened since COVID. As I said, our program provides CRC screening services coordinated throughout our entire state by regionally located patient navigators. We do an individualized approach to navigation to provide CRC education and full colonoscopy instruction to the medically and underserved and uninsured individuals. And we've been able to attain exceptional compliance in both FIT and colonoscopy screening. Last year, we are very happy to report that we had a 98% compliance to FIT screening as a result of in-person navigation and the use of poop on demand, which out of the 98%, 31% were completed through poop on demand. So I'm assuming that most of you are familiar with poop on demand, which was developed by Dr. Endrick in Florida. We've kind of R&D'd her model within our program prior to COVID, and we saw great success with that. We also have achieved less than a 2% no-show rate for our colonoscopy patients. So of course, back in March, I think all of us had to close down our navigation and screening programs due to COVID. So during that time, we did a lot of thinking and researching of what we needed to do to be able to navigate patients safely once we were able to return. So we transitioned our in-person FIT navigation to a virtual model, and we launched that back in June, and we are seeing an 83% return rate for our FIT test using our virtual model, which we are very pleased with that result so far. Let me go down here. Okay. So, so just to kind of give you a basic overview how our program works, we partner with federally qualified healthcare centers, free medical centers, and indigent care programs to target screening for those without resources throughout the entire state of South Carolina. We currently partner with over 120 clinics throughout our state. We have open access colonoscopy, early screening, follow-up colonoscopy less than 1 year, FIT screening, colonoscopy due to positive FIT. Those are the referrals that we accept at this point in time. We will be expanding to do surveillance for those who receive a colonoscopy through our program, and the GI deems that that patient needs to be seen in 3, 5, or 7 years. We will be implementing that program in December. So we are expanding our services for colonoscopy. I'm very excited about that option. Our patient navigators confirm eligibility criteria and coordinate aspects of the screening and remains in contact with participants throughout the process. We have GI providers and anesthesiologists that donate services to participants served. They are basically, they provide all services and we do not pay them any fees. We do provide a stipend to the facility for facility fees and for pathology for services. And it's a flat fee for the pathology, so it doesn't matter if they take 1 polyp or 20 polyps, it is one flat fee. And then we actually have a virtual database where the clinics can access 24 hours a day to see where their patients are in regards to the screening process, and also to access the results. They can download the results from our database and upload them into their EMR system. And then the continuity of care is the responsibility of the referring clinic. So if we do have a patient that needs surgery or other needs, we work with that referring clinic to help identify resources for that patient. So how do our patient navigators work? They actually start the conversation with the patient through a phone call. After the navigator has completed a chart review and the patient has been deemed to meet our medical criteria, they reach out and they really truly start the conversation with the patient in regards to family and personal risk. We also not only have our navigators start this conversation with patients that are referred, but we also, when we are training providers and clinic staff, we also encourage them to start the conversation with their patients at around age of 18, because it's really, really important for people to understand their family and personal history of colorectal cancer and how that impacts their risk for colorectal cancer. We also know that many families do not talk about colorectal cancer. It's because it's not a polite conversation. We normally avoid conversation about poop, our bowel movements. It's just been, since we were little, consumed, oh, we don't talk about that, that's icky kind of thing. So we really are trying to change that perception around colorectal cancer, and that it's a very important conversation that you need to have with your family, because you need to know what their history is and how that impacts you as an individual, and how your history impacts your family members too. So our navigators start the conversation with the patients that are referred to us in regards to knowing their family history and personal history. We have developed 4 quick questions that clinic staff can use, or you can use these out, like if you're at a health fair and things like that, so that these individuals can do a quick assessment to determine if they're of average risk or of increased risk, and encouraging them to speak to their providers about their answers to these 4 questions. Question 1, have you had a parent, brother, sister, or 2 of the following on the same side of the family, grandparent, aunt, uncle, diagnosed with colorectal cancer, precancerous polyps? That is a sign of increased risk, and also may be indicative of that person needs to be screened prior to the United States Preventive Task Force recommended age of 50, especially if their family member was diagnosed before the age of 60. In the past 2 years, have you noticed blood in your stool or had other symptoms such as diarrhea, constipation, cramping stomach pain, or unexplained weight loss? So we also know that in some of our clinics that patients are just receiving fit kits without really having a risk assessment done. And we also know that a lot of patients do not speak to their physician about blood in their stool. So this question specifically really addresses, have you had blood in your stool? And it also addresses other symptoms that patients sometimes dismiss. And these could be symptoms of colorectal cancer. So we really are wanting to draw their attention to, have you had any of these on a consistent basis? You need to, talk to your physician about that. We also want this question to be a flag for the physician or the provider that this patient is not conducive for or right for a fit test, because if you had blood in your stool, that test is automatically going to come back positive. So question 3, do you have a history of precancerous polyps from a prior colonoscopy? And 4, have you ever had a positive take-home stool test? So these are 4 quick questions that we use within our program and out in the community when we're doing education. Medical literacy and compliance. We all know that we can all have a high overall literacy, but you still may have a low health literacy. So how do you overcome these barriers, especially with your patients and other people that you're speaking out in the community about colorectal cancer? One, strongly, which many of you probably already know, use layman's term. Instead of saying fecal material, say poop or stool. So instead of saying polyp, say growth in colon. And just call blood. Just talk their terms, make it easier for them to understand. We love lots of visual aids in our program. As you can see, we have some of the examples of the visual aids that we use. The one on the far right-hand side is our fit how-to instruction that we provide our patients. You can see there is some verbiage, but there's a lot of photos. So that way the patient, either if they are not able to read, they can see the pictures. So this is one of our cards that we use to draw attention. The GIF is one of our interactive videos that we use for education. It's just a little snapshot. And then of course, this is just a picture of our FIT materials that people are provided. Of course, the one-on-one education, which is where you come in hand. You are a patient navigator, so you already are the one performing one-on-one education, and you probably use posters and videos and handouts and photos. That's probably something that you do automatically already, but just want y'all to know we also do those things too. Signs and symptoms, one of the things that we do cover in our navigation is signs and symptoms of colorectal cancer. And this is just a little freeze frame of one of our videos that we do sometimes use with education. And all our videos are on our website. Renee will be sharing some of our other videos when she presents. We also highlight the fact that colorectal cancer has been described as a silent killer, and many people never experience symptoms before being diagnosed. Let's see. It's funny how it works. And the other thing that we also highlight in our education is that things that you can change that impact your risk, not just for colorectal cancer, they also impact other risk factors for various other cancers. So we also draw attention to these habits when we're providing our one-on-one education. We also, for those individuals that are identified as tobacco users, we do ask if they are interested in cessation, and we do connect them to the South Carolina Quit Line and tobacco cessation resources. So we also highlight, things that they can do and things that they can't change during our navigation and education. And now I'm going to turn it over to Renee.
Thank you, Tracy. So when we navigate our patients, we are very, very focused on engaging the patient. We do meet with our patients for colonoscopy still in person. FIT is now virtual. But one of the things that we really focus on is what is motivating the patient. Is it a health issue, just health improvement, health protection? Is it something about their family that they feel moved to do this? There's lots of different motivating factors for that patient. Creating a trusted environment is very important with us, as I'm sure you do as well. We use the referring clinic medical home, so we actually drive to the patient's medical home to meet them. We are very strategically focused on addressing fears, barriers, and concerns. We provide a PowerPoint presentation to the patient that enables them to see things in context, but also promotes an opportunity for dialogue with the navigator so that they can, there's some things that use a little bit of humor, lots of pictures and lots of pictures. We love pictures with our patient education, and open up opportunities for our patients to engage and to feel more relaxed. And we have, I would say, I'd like to say we've heard everything, but every month surprises me. We have heard some very interesting comments and some very interesting scenarios. So, nothing catches us off guard. We make sure that we keep a very poised view, but it's very interesting to see how people can be very creative, or how just nothing is filtered. And the most important thing is to smile. We always want to make sure that our patients meet us with a welcoming smile, and to know that we are excited about them getting screened, and hopefully they will be as well. Next slide. So one of the big things is, when we're talking about the colon, is poop. And the ick factor is something that we all have been exposed to. And when we were raised and young, we were told that poop was icky. And so some things that we've done to overcome this are, for colonoscopy, we address the fears of prep. Patients have fears that they will defecate while sleeping, or they won't make it to the toilet, embarrassment that other family members may be there, or why they need to take off work, or the caregiver that's even providing them transportation. So we do work with that with the patient. Also for fit, we provide gloves. Even though they're nowhere near touching it, it's just a comfort measure for our patients, and it's very successful. We do explain that they are not touching the stool themselves, and that it's an test that provides screening in the clinic at home. And we go through that whole process. Tracy, next slide. And so some of the images that we use of why a fit and what it does is we use this for colonoscopy as well, is this is what we're looking for. This is a nice, pretty, clean colon, and this is what we are wanting to have success with your colon prep. And what the provider is looking for is a polyp. And there's several ways of removing a polyp, and we explain this to them. And then we explain to them how that process moves on after that. But we're all very focused on making sure that the patient feels comfortable and that they are fully monitored and that their privacy is respected. We have a lot of that with our Muslim community, and our African-American men are also very fearful of being sedated. And so we try to help them overcome those fears. Next slide. So this is a snapshot of a little project that we had our patient navigators work on the COVID crisis. And we had already created a large amount of our videos, and we had 2 to go. And one was a clear liquid diet video, and the other was a fit education video. So we got our navigators together and said, let's have you come up with a scenario. We have a very diverse group of patient navigators, and you come up with a setting and let's talk. And so we help guide them, but they came up with this idea, and it's absolutely fantastic. That's an example of our clear liquid diet instructions sheet right there on the refrigerator. And this is our Frosty, the refrigerator, and that's our nice friendly barber getting ready to go to work. And he is being talked to by Frosty about his clear liquid diet day. And y'all are welcome to go on our website and view that. It's about 3 minutes long, but it covers a lot of the components of a clear liquid diet for that day and puts it into a little jingle form that may not leave your head anytime soon. Next slide. So some of the visual aids that we've used are these. We do roll up lots of colors of Play-Doh, put them all together, and they make great little poops. These are great. Patients laugh about this. They think it's funny. They're like, oh my goodness, I can't believe you've done that. And I'm like, well, you know, this is what we do. And we show them how to sample the stool. This is really important in our program because even though we go through detailed instructions, it never fails. We get someone who either puts it in the paper that you roll up with the fit kit, or they just, they do all kinds of means to get that in the tube. Very creative. So we always use some examples. Our in-person settings are always very, very helpful. And then we use the bottom slide here talking about the function of the colon as well. And that picture with the bleeding polyp is a great, great motivator of why we need to do a fit test or a colonoscopy. It works great in both of our programs, and we've used it for a long time. Next. So the contents of our fit packet is one, we do navigator education over the phone. They have already been sent their fit kit. They have their instructions on the front, and then we have images to assist patients with language or reading barriers. We also have this in Spanish. And then we have gloves to address the ick factor. We have a postage paid envelope for return. And because of some challenges with missing fit kits in the mail, we now track our kits to the patient's residence and on the way back. We have noted a definite change in postage challenges since the COVID crisis. We did not really have many problems with it initially, but we are finding that some of our packages are getting left at the post office. They're getting delivered to the patient's address. We tried to change it to another location. So now we have the return address and the delivery address is the same. But we do put tracking number labels on there because we certainly don't want to dishearten our patient who has taken the time to finish a fit kit and tell them that, well, the lab never received it. This is just another reassuring way for them that we do believe them. And then we can also determine when another kit just should be sent. With FIT in our education, there are no surprises. We're very upfront with patients and we let them know when you have a negative test, you'll be reassessed next year and you can have another FIT kit to complete, as long as you don't have any changes in your family or personal medical history. If it is positive, we do provide our patients with detailed information about the colonoscopy. And in our program, as long as they still financially and medically qualify for our program, they can get that colonoscopy due to a positive fit, again, at no cost. All of our services are provided at no cost to the patient. So FIT education in any setting. So this is on our website, and since we're predominantly talking about FIT today, we thought we'd show you our little video that we created this summer. I hope you enjoy.
Yes, now it's not working. Hold on. Maybe I'll just go and get it from our website. Hold on. Let's see here if I can get to my, there we go.
We apologize. Somehow in the process, the play button has disappeared. So Tracy's working to download that from our website.
Oh, is it not showing, Renee? Because I have it playing.
It is not running.
I think
Okay,
you'll have to stop sharing this screen and then share the screen, the video.
Okay, thank you. That makes sense. Sometimes it works like it's supposed to, and other times it doesn't.
Zoom has a mind of its own.
Yes, okay, let's see here. Let me go back to share my screen, and here it is. Nope, not that, this one. Share, and let me start it from, do y'all see it now, the video?
Yes.
Okay, there we go.
There's no sound.
No, there's not any sound.
Do y'all hear it?
No, there's no sound.
No. Huh.
You could also send me the link and I could share it.
Okay.
If you just want to
Yep.
put the link in the chat, I'll bring it up.
Okay, sounds good. If it's letting me, let me stop sharing. And then let me pull it back up. So sorry for the technical difficulties.
No
Okay.
worries. While we're getting this set up, everyone, this is a great opportunity to think about what questions you might have for Renee and Tracy. And if there's any strategies that you all have been working on at your own clinics that you'd love to talk to them about, I think they would love to have a brainstorming session as well about overcoming some barriers, especially in the new COVID age. Okay, I'm getting the video pulled up. And this is the how to use a fit kit one, correct?
Yes, that's correct. Mm-hmm.
Okay. All right, can you see my screen okay?
Yes.
Yes.
And can you hear?
What do we have here?
Oh, that's my fit kit. It's time for my colorectal cancer screening.
That little kit can screen for colorectal cancer?
Yes, it's one way to screen for colorectal cancer. Colorectal cancer begins in the colon or rectum from a small growth called a polyp. A polyp is a growth of tissue that is formed from a group of cells. Not all polyps will grow into cancer. Cancer happens when the cells in the polyp grow out of control. The fit kit just looks for hidden blood in your stool, which can be an early sign of an aggressive polyp or colorectal cancer. Since I have no family or personal history of colorectal cancer or polyps, I'm able to use the fit kit.
I like the idea of completing the test at home, but I don't want to touch Dookie.
I'll just relax. I pee before I go number 2 and flush to make sure I have fresh water. Then just lay the paper insert provided in the kit on top of the toilet water. Then I just sit on the toilet and go. To collect my sample, I open the sample container and gently scrape the outside of the stool to make sure the sample covers the ridges of the stick completely.
Look, a pooper scooper.
Okay. Then I insert the stick back into the container and twist the lid firmly. The paper and stool is flushed down the toilet. After that, you just place the bag in the envelope provided and mail. Piece of cake.
I'll pass on that cake, but I think I can handle this.
If the test is positive, it means blood is present in my stool. My doctor said I would need a colonoscopy to look for the source of blood, which could be from a polyp, cancer, or other reason.
Wow, this is really important.
It is. But if the test comes back negative, like last time, and I've had no changes in personal or family history, I'm able to do this test again next year.
Well, I don't want to be a party pooper. I'll talk to my doctor about my colorectal cancer screening too.
Thank you, Elsa.
Yes.
Absolutely.
And let me get back to presentation.
Wonderful. Thank you, Tracy.
You're welcome.
Well, one of the important things that we reinforce in our program is don't stop at no. We talk to our providers about this and as well as their clinic staff, and reinforcing the importance of screening. We have found in our program, some patients get referred 2, 3, 4 times to our program and may either decline or not even answer the phone when we call. But we get calls all the time that say, you know, our navigators will call us and say, this patient, I've been trying to reach her. I see she's been tried to reach for several years now. She's decided she's avoided us long enough and she's going to go ahead and get screened. And this is important for the provider side as well. If you tell patient it's really important, you should continue to reinforce that, even if they have said no. The importance of reinforcement is very, very important. In our program, and as anybody else knows, when your doctor says you got to do this and they keep bugging you about it, eventually you're probably going to do it. We recommend screening regardless of insurance status, and readdressing the needs at the next visit if the patient continues to decline. And then lastly, we are all in this together. Everyone must be encouraging. It's really sad to see a provider spend a lot of time with a patient and have that patient on the bandwagon to get their screening and pass someone that works in the clinic in the hallway to say, hey, I'm going to get my screening, and they downplay it and say, you won't catch me doing that. I'm not going to do this. It tastes ucky, or I don't want to touch poop. And all that hard work by that provider or the nurse or anyone, it really loses the motivation with the patient, and the patient may not complete. So we really drive home that everyone must be encouraging, laugh, and have fun. We have lots of laughter in our program, provide lots of reassurance and support, addressing barriers and concerns, and making sure that someone is available in case they have questions. And then the clinic in our program follows up with the results for the patient. And we've listed some resources here. I hope you've enjoyed our presentation, and we would certainly love to answer any questions that you have.
Thanks so much, Tracy and Renee. Love to hear what other groups are doing, and that video had really great visuals and was really simple. So we're always looking for resources to share with our navigators and for the patients that are really visually appealing and simple. One thing, while people are coming up with some other questions, I'd love to hear a little bit more about the Poop on Demand program. I do know the basics of it, but I'm not sure that everyone on the call here does today. And there's always people looking for different ways to get patients to complete those fit kits. So could you talk a little bit more about your Poop on Demand program and why it's been so successful?
Sure. Renee, would you like to take that question?
If you want to start it, I'm going to pull up our PowerPoint about that.
Okay, perfect. Yeah. So, so back in 2015, Annie Thibault and myself, at the time I was working for the American Cancer Society, formed the Southeast Colorectal Cancer Consortium. And we were looking for best practices, speakers that could come and present at this first ever meeting of the Southern states. And Dr. Bembeck-Endrek was recommended to us to reach out, that she was doing an innovative technique to with her patients to complete fit when they were in the office. So we reached out to her, and she was very excited to come and present. So her clinic, which is an FQHC in Southern Florida, they were providing fit to their patients, but the return rate was very low. Like they were only getting 6% of their fit returned back to them. So her and her staff kind of had a brainstorming idea, you know, how can we change this number? And one of her staff says, let's see if they'll complete the fit kit while they're here. So with that in mind, they came up with the concept Poop on Demand. They actually designated a bathroom in their clinic for Poop on Demand. They put like the poop emoji on the outside of the door. They put how to complete fit instructions behind the toilet seat. And they had a couple other visuals within that bathroom. And when the nurse or the MA or nursing assistant was calling to remind that patient of their visits the next day, they were also prepping that patient saying, you know, while you're here, the provider's going to talk to you about your colorectal cancer screening. And if you're eligible for FIT, the provider will recommend you to do FIT. And if you're able to have, you know, complete your test while you're here, have a bowel movement or poop while you're here, you'll be able to complete your test. And so they went from a 6% return rate on their FIT to over 60% by them implementing Poop on Demand within their clinic. So it was a very successful model. So after we heard her presentation in 2015, Renee and Annie came back and looked at see how they could implement Poop on Demand within our screening program. I will turn it over to Renee to talk about how she implemented Poop on Demand in our program and the successes we've had with it.
Thank you, Tracy. I did find the one piece that we had in here.
Yeah.
I was hoping to flip back the slide, but it's not letting me.
Do the arrows back on the left-hand side, Renee.
Right.
That works.
Okay. So they used the Play-Doh, which we have replicated. They put a sign inside that had all the instructions. We did the same. We had a large laminated sheet. All of our materials are very sensitive for vision changes. As we get older, our vision naturally matures and requires some assistance. And many of our patients, because of their economic status, cannot afford to have corrective lenses. So we did very large posters, put them in the bathroom behind the door, and then on the front door itself. The clinics use this as well during our program and for their own patients, and we used it for ours. And so basically before they came in for their education visit, we let them know that we would try and collect a sample if they were willing during their visit that day. And we've had patients that make jokes about it. I'll bring my coffee and a magazine. I'll be ready. I have to do, you know, so many laps around my block before I'm ready, but I'll do that before I come visit you. And we had, you know, the patients had a lot of fun with it. And if you can't, you can't. Some people definitely can't regulate. They're not that regular that they can determine when they're going to go. But the patients that did were very engaged. We clapped our hands, gave them a big attaboy. You know, you've just completed your screening. Congratulations. That was so easy. And so it was a great success. And then we do follow up as well. The navigators would take the kit and then put it in the mail that day.
Yeah. So of course, with us switching from in-person navigation to virtual fit navigation, our Poop on Demand has ceased at this point in time because we are only performing virtual navigation for our FIT program, which is one of our things we had to adjust due to COVID at this time. So we're hoping to go back to in-person one of these days. But our virtual navigation has been very successful, just even with seeing the 83–84% return rate for our FIT kits. The tracking, putting the tracking numbers have been very helpful for us in regards to verifying the patient has received the kit and also verifying that the clinic has received, the lab has received the completed kit.
Yes, I know that the setting up the tracking and making sure the postage and the envelope size is the right dimensions has been a challenge for some of our clinics who've tried to set up a FIT kit, but it's a mailed FIT program, but it's really encouraging to see how you've been able to set that up. So yeah, if there's any tips you have for navigators or clinics that want to get started with a mail to fit program, we'd love to hear about that as well.
So our mail to fit is we do an assessment over the phone for a risk assessment, make sure that they are in fact average risk. If they are, then we tell them, we let them know that they're eligible for that program. And then we just let them know that we'll mail the kit that day, and we coordinate an education visit with them on the phone 3 to 5 days later, depending on where they live, depending on the remoteness of where they live. And then the navigator calls them, checks in. Did you receive your kit? Yes. One thing that we do for tips, quick and easy tips for your patients for compliance is tell them to put it on the back of the toilet. Because there's nothing worse than starting to have a bowel movement and go, oops, I left it on the kitchen counter, or it's in my purse, or it's on the credenza, whatever. So we always tell patients to leave the kit on the back of the toilet. That's always nice and handy. But when our patient navigators call them, we do the education. We ask them when they normally have a bowel movement. And then we'll follow up with them about that much time, whether it's 24 hours, 48 hours. We'll follow up with them, ask them if they mailed the kit, and then we'll start tracking at that point.
Great.
And we'll call them up to 6 weeks. We see our greatest return rate within the first 4 weeks, but we do pick up several between weeks 5 and 6. So we really truly give a 6-week window of time.
Yes, we were just on a call talking about the importance of repeated messaging. So sometimes, I know most of our navigators try to do at least 3 contacts, but you'll definitely be surprised how many people with just that final message, it gets them to the point where they're ready to.
Yeah, that last little push going, you can do it.
And go ahead.
I was just going to say, we reference our database system at the beginning of our presentation. We actually put our tracking numbers for that fit kit under that patient's ID in our database system. So that it's easy for our navigators to say, okay, I mailed Jim Smith fit kit on November 1st, tracking number was this. So they can also go into the UPS and see where it is, if it's been delivered or not. That also serves as a trigger for them to call the patient and say, hey, just noticed your fit kit was delivered today. So we do have in place a designated place where they put the tracking numbers in that are associated with each one of our participants. So our database does help. I'm not sure how your navigators coordinate and how they, follow their patients, if it's through their clinic's EMR that they're tracking the patient. So for me, it'd be interesting to hear how they track their patients, if it's using the clinic's EMR or if they have a different system.
Because ours, the information that Tracy's mentioning, it creates a report every month. I think it's every 3 weeks. It creates a generated report to let them know what kits have not been sent in, and it actually gives them the tracking number now. So they don't even have to go into the system. They just sit there and search the tracking numbers to make sure none of them have been currently mailed, and then follow up with the patients for those that have not been.
I'd love to hear, from some of our navigators on the line, what's worked well for you. So some of our clinic systems are more colonoscopy focused as the initial screening method, both for average risk and those that need a follow-up, as well as some of our other clinics are transitioning towards stool-based testing as the first line of screening for average risk patients. So Carla from Marillac or Laura and the Valleywide crew, Lupe, would love to hear a little bit what's coming up for you around thoughts for tracking or any other questions that you have for Renee and Tracy. So go ahead.
It's Carla at Maryland Health. So I'm really excited about this group on demand, and I think it's something that we can work at the clinic. At this point, what we are doing just additional to the fit kit, we give our patients a hat, so where they can go just I don't know if you know which hats I'm talking about, but it's the one that you put on the toilet, inside the toilet, and it kind of stays there. So it makes it really easier for them. And so I'm actually, we're thinking about, as you guys were presenting, which I think is exactly what you have been doing. Maybe this is something that I can bring with my next meeting that we have, and see we can find one champion that can start working on it, and see if they will be doing this, and I can give you feedback afterwards.
Hi, this is Laura. I also like to poop on demand. I don't know how receptive our patients would be, but I think it's a great idea. We don't have a very good return on the fits, and we do remind the providers and the nurses when we huddle every morning, when we see someone come up on the huddle report, that they're in need of a colorectal screening. So we continue to push that. But our nurses do a really good job of explaining how to do the fit with our patients. So that's something I think that our navigators could also, and I think they already do, remind the patients that if they don't want a colonoscopy, if they're able to get a fit, that's also an option.
Right. I mean, I'm sure y'all are fully aware that, I mean, that when a patient is given options, that does increase compliance to screening, specifically for colorectal. So if, if the provider is, if they're increased risk, of course, they only have one option is colonoscopy. But if they are average risk individuals, they really truly have multiple options for screening. So, and having that informed decision-making conversation between the provider and the patient really truly helps that patient feel vested in their decision, and also in regards to completion. We also know, which I'm sure y'all are aware too, that NCCRT did some focus groups, and that 90% of all patients who receive that provider recommendation will complete their test. So that provider does play a huge role in that patient desire to complete the test. And I know Renee hit on this about, it's really a whole team approach, because we have seen it several times in our program where a patient has been, the provider has taken the time to talk to that patient. The patient's walked out into the hallway, and one of the staff from that clinic said something negative about the screening, and therefore that patient didn't complete the screening. So it's really truly making sure that everybody has an investment in promoting colorectal cancer screening. It can't just be the provider. It can start, and y'all probably know this, it can start from the moment that patient, before the patient comes in, with the reminder, hey, you have an appointment, you have been, identified as an individual for colorectal cancer screening. Your provider will be talking to you about your options, so just already going ahead and setting that, just, that in that patient mind also helps. And the other thing is really truly having the clinic adopt colorectal cancer as a whole, and really starting that conversation with those patients when you're doing the height, weight, blood pressure check, of asking those family questions, because the only way you're going to be able to identify individuals who need early screening is knowing that patient's family and personal history. And if you wait until they're 45, if United States Preventive Task Force actually does adopt that measure, that may be too late. That patient may have needed to be screened at 35. I actually have a friend who's her 18-year-old had to be screened because of family history. So if her mother wasn't such an advocate and knowledgeable about colorectal cancer, her child would have never been screened on time, and her child had 2 adenoma polyps removed at the age of 18.
Wow.
So it is very important to really start that conversation at an early age, because if they can't answer the questions at 18, that gives them a better chance of finding out the answers of their family history. Like we said, most people don't talk about their screening, colorectal cancer screening, their results, or even if they've had polyps removed. They may not have had cancer, but they may have had adenoma polyps removed. But, you know, all they tell everybody, if they even say, oh yeah, I had screening, all was good. So it's also very important to start that conversation so that the clinics have the opportunity to identify those patients that need to be screened early. We also know that early onset of colorectal cancer is on the rise. So we also need to draw attention to the younger population that it's okay to talk to your doctor about problems you're having digestively. It's okay to talk to them. You need to bring it to their attention. And also we need to educate the providers that you need to pay attention to these younger individuals that are showing up with symptoms. Don't automatically rule them out for colorectal cancer because they're not 45, 50, 60 years old. It's no longer an older person's disease.
And one additional benefit of asking your younger people about symptoms and family history is this generation is all about communication, all different types of communications. And I promise you, they're going to start looking things up and they're going to ask their family and they're going to ask others. Another big motivating factor that we talked about earlier is what is motivating the patient. What is it? Is it because they have a family history? There was a great focus group, as Tracy mentioned, from the NCCRT, and it was among the Hispanic population, but it really works across many different ethnicities, is what do they respond to? And one of the things that I thought was just great was they respond to guilt. So we use it not in a negative way, but in a positive way. And so, you know, someone that says, oh, I don't want to get a colonoscopy. Oh, do you have brothers or sisters or children? Oh, I've got, 3 children. I said, oh, well, did you know that you're actually protecting them by getting your screening done? Because if you have polyps, you're going to know they're at increased risk and they're going to need to have their screening younger. If not, they're going to be waiting until this end time when average risk people and, things happen. And we want you to get screened. You can protect your family members and your children by knowing what your risk is. And this is a big motivating factor, particularly among men and African-American men. It works exceptionally well.
Thanks so much. Those are really great reminders. I know our navigators are really great champions, and we have a lot of other champions at our clinics, but there's always the opportunity to involve the whole clinic team. And those were some really great informational reminders of different tactics you can work into the conversation. We are right at the top of the hour, so I do want to make sure I wind up everything for the day so that we give people back the rest of their time. But I would encourage everyone on the phone today, if you have any additional questions for Tracy and Renee, to reach out. And then also the CCSP team is happy to work with any of you if you are interested in moving forward with exploring a poop on demand type of approach. We're happy to work with you on that if we want to get that set up. And I will definitely include in the follow-up email the recording of this presentation, the slides, and then also the links to the videos and the resources that the South Carolina team has. And Tracy just put in the chat, crcfacts.com as well is their website. So thank you so much. It was really great to hear about a fresh perspective and what some other states are doing.
Elsa, we also can send you Dr. Endrick's presentation that kind of outlines how she set up Poop on Demand in her clinic. If anybody, you can share that out as a resource also. So
great, that would be super helpful. And yes, as we're working with clinics and if they have additional questions about the Poop on Demand, we might reach out to some of you all as well. So thank you so much, everyone. Have a great rest of your afternoon and go vote if you haven't already. Bye-bye.
That's right.
Take care.
All right.
Bye-bye,
Bye.
everyone.